This video has been produced to highlight the principles of wearing and using personal protective equipment, PPE, safely when dealing with patients who may be suffering from viral hemorrhagic fever.
Hello, I'm Bob Winter. I'm the National Clinical Director for Critical Care, Emergency Preparedness, Resilience and Response. This film is part of a training package on the use of personal protective equipment or PPE for hospital-based NHS clinical staff caring for patients suspected to have Ebola or another viral hemorrhagic fever. It is particularly aimed at clinical staff working in emergency departments and infection-related specialties including microbiology. This PPE training is needed because whilst the Ebola outbreak in West Africa continues, it is possible that an individual with Ebola infection could arrive in the UK and subsequently present to the NHS for diagnosis and clinical care. At the time of the making of this film, there is ongoing rural and urban community spread in 3 countries, namely Sierra Leone, Liberia and Guinea.
I'm Dr. Emma Ahrens. I'm a consultant virologist and infectious diseases physician at the Rare and Imported Pathogens Laboratory at PHE Porton. This is where we do diagnostic tests for and research on viral hemorrhagic fevers such as Ebola. I'm also a member of a WHO group that has recently published guidelines on the personal protective equipment needed for the clinical care of patients with Ebola virus disease. The main route of transmission of Ebola virus is by contact of the mucous membranes of the eyes, nose or mouth with infected body fluids. That contact can occur either when splashes or droplets of body fluid land on those mucous membranes, or when somebody touches their eyes, nose or mouth with contaminated hands. Transmission can also occur via sharps injury or if broken skin comes into contact with infectious material. However, there is no evidence of transmission across normal intact skin, and nor is there any evidence of transmission of Ebola via the airborne route. Ebola virus disease, or EVD, typically begins as a non-specific febrile illness. So, for example, a fever accompanied by feelings of weakness, lethargy, headache, and perhaps myalgias. At this time, the virus is replicating in the blood, but not to any significant extent in other body fluids, and therefore the patient is not particularly infectious to others. However, over the following few days, the virus replicates increasingly in the blood up to high levels, and patients very often develop vomiting and diarrhea. As the diarrhea can be profuse, up to 6 litres per day or more, and there is high levels of virus in the diarrhea, patients with advanced Ebola virus disease can be highly infectious. Ebola viruses, unlike norovirus for example, are relatively fragile. They're easily destroyed by the kinds of disinfectants usually available in UK hospitals, and also by alcohol and soap and water. Wearing PPE to cover the eyes, nose, mouth and hands will protect against splashes and droplets and hand contamination, but only for the duration that the PPE is actually being worn. If during or after the removal of PPE the hands become contaminated, and if hand hygiene isn't performed, then there's a real risk that an individual could unwittingly transfer virus into their eyes, nose or mouth. So to avoid contamination of the bare hands, either during or after removal of the PPE, it's absolutely essential that the procedures for removal and for discard of that PPE and the procedures for decontamination of the area in which it's been taken off, it's essential that all of those procedures are absolutely meticulous. The majority of patients in whom Ebola is initially suspected will turn out not to have this infection. But the PPE demonstrated in this DVD would be safe for looking after an Ebola patient whilst awaiting their test results, even if that individual did have diarrhea or vomiting.
This is the algorithm published by ACDP for risk assessment of suspected Ebola cases in secondary care. It is vital to use the most recent version of the algorithm available on the internet. Search on Ebola PHE, then follow the link to Ebola virus disease Clinical Management and Guidance. Scroll down and click on the first link under the Clinical Management heading. It's important to work systematically through the algorithm from the questions at the top in order to identify the patient as unlikely to have VHF, low possibility of VHF, or high possibility of VHF. The most recent version of the algorithm and guidance, which was issued in November, has been simplified so that there are now just 2 levels of PPE. These are shown in the yellow and orange boxes. For looking after patients designated as low possibility of VHF, the PPE required is hand hygiene, gloves, and a plastic apron as shown in the yellow minimal risk box here under infection control measures. As ever, for any splash-inducing procedures, eye protection and a fluid-repellent surgical face mask should be worn. Using the algorithm, you can see that somebody who has developed a febrile illness within 21 days of their return to the UK from Sierra Leone, Guinea or Liberia will be classified as high possibility of VHF. For looking after patients designated as high possibility of VHF, the PPE required is indicated in this orange staff at risk box. Hand hygiene, double gloves, fluid-repellent disposable coverall or surgical gown, full-length disposable plastic apron, a surgical cap, fluid-repellent footwear, face shield, fluid-repellent FFP3 respirator.
This procedure outlines best practice for putting on a specific coverall-based combination of personal protective equipment or PPE. It is for those NHS staff providing clinical care for patients designated at high possibility of viral hemorrhagic fever according to the VHF risk assessment algorithm produced by the Advisory Committee on Dangerous Pathogens, ACDP. It is in line with advice from ACDP, Public Health England and the Health and Safety Executive.
This film does not cover the dressing of the safe undressing assistant, as the PPE required for this role, theatre clogs, 2 pairs of nitrile gloves, a fluid-resistant gown worn over scrubs, and a disposable face shield, is straightforward and should be familiar to clinical staff working in emergency departments. The PPE shown in this demonstration comprises fluid-repellent single-use coveralls, as available from NHS supplies, Wellington boots, fluid-repellent apron, a surgical cap, FFP3 respirator, a rigid plastic helmet face shield, 2 pairs of longer cuffed nitrile gloves. Other equipment you will need is a clinical waste bin for each of the clinical workers, bottles of alcohol gel, tubs of clinical wipes. The clean area in which individuals put on their PPE should be physically separated from the high-risk area in which they take off their contaminated PPE. This is so that there can be no possibility that a clinical worker could become contaminated whilst preparing to enter the isolation room. The area shown here is completely separated from the patient's room and has been divided into a high-risk red zone and a low-risk amber zone. The different areas have been marked on the floor using tape. Bins for clinical waste are placed in the red zone close to the line which separates it from the amber zone. The dressing procedure requires at least 2 people. They should check each other to make sure that the procedures are carried out correctly. The dressing procedure should be carried out in a clean zone. Before dressing in PPE, the clinical workers should wash their hands, check that they are wearing scrubs, are well hydrated, have removed all jewellery, have tied up their hair and have covered any minor cuts. They should gather and check their PPE to ensure that they have the correct equipment and that it fits. Put on the coveralls and zip them up to the neck. Stick the neck tag back on itself. Put on the Wellingtons and pull the legs of the coveralls down over the boots. Fit the apron high on the chest and tie at the neck if necessary.
Is that high enough?
Yeah.
Because there is minimal risk of getting splashes on the back of the head in this clinical environment, it's not necessary to wear a hood. The hood should be rolled back inside out to keep it out of the way. The surgical cap is used to prevent the respirator or face shield straps from catching. Put the respirator on and fit check it. Ensure that the lower strap crosses over to the top of the head. This will facilitate easier removal of the mask later.
That's quite straight.
Yeah, that's on.
Both straps should be above the ear. Put on the face shield and adjust the size to fit. Put on the inner gloves, ensuring that they are tucked under the cuff of the suit. If there is a loop attached, put it over the back of the middle finger or thumb. Put on the outer gloves and pull them up over the cuff of the suit. Each of you then checks the other to ensure that the PPE is fitted correctly. Use a marker pen to write names on your aprons for the benefit of patients. Once dressed, the clinical workers can then move through the amber and red zones into the isolation room. Before the clinical worker leaves the isolation room, the safe undressing assistant, the SUA, seals any bin used by previous staff, moves it and replaces it. In the isolation room, the clinical worker uses wipes to remove any gross contamination before entering the red zone. The safe undressing procedure requires a minimum of 2 people. The clinical worker is directed where to stand.
I'm going to gel your hands, Mike, and then you just need to rub it in.
Clean your gloves with alcohol gel.
Okay, take your apron off now, Mike.
Remove your apron by pinching it at the shoulders and pulling it down. Keeping the outside facing away from you, remove it. Fold the apron and place it in the bin.
Rub your hands together again, Mike.
Clean your outer gloves using alcohol gel.
Okay, and now remove your gloves, please, Mike.
Remove your outer gloves in the manner shown, being careful to ensure that they are removed inside out. It's recommended you practice this beforehand if unfamiliar with this routine. Place them in the bin.
Hands again now.
Use alcohol gel to clean your inner gloves.
So we're going to take your suit off now, Mike. So if you want to just turn around this way and lift your head up.
The SUA then unzips the coveralls and takes one step
Okay, Mike,
back.
if you want to turn around now, I'm going to take your suit off.
Turn through 180 degrees.
If you hold your hands out to the back, please.
Gripping the coveralls at the shoulders, the SUA removes the coveralls, pulling down so that the clinical worker can pull their arms out of the sleeves. Clasp your hands together in front of you, while the SUA rolls the coveralls outwards down to the ankles, making sure they don't touch the clinical worker's scrubs.
Okay, if you want to put your left hand on the bin, Mike.
Place your hand on the upturned bin to steady yourself, and when instructed,
I'm going to hold your right boot. Step out with your right foot.
Step out of
over
the
red
right
line.
boot and place your foot in the amber zone.
And the same with your left foot.
And again for the left foot. The SUA gathers up the boots and the coveralls and puts them in the bin. She then removes her outer gloves. Whenever gloves are removed, they must always be removed inside out as shown previously. The SUA applies alcohol gel to the clinical workers' gloves and their own. As there is a second clinical worker requiring undressing, the SUA now puts on a second pair of gloves.
Okay, Mike, if you want to take your helmet off.
Remove the face shield and place in the bin.
Okay.
Clean your gloves with alcohol gel.
Rub that into your hands.
Remove the FFP3 by pulling it away from the face with one hand, and remove the cap at the same time with the other hand. Clean your gloves with alcohol gel.
And if you want to take the inner pair of gloves off now.
Remove your inner gloves, once again being careful to turn these inside out. Place them in the bin and then wash your hands in soap and water. If there is a second clinical worker who will need to take off their PPE, the SUA now seals and replaces the bin.
Okay, if you'd like to come over to that. And alcohol gel your hands. Okay, and if you'd like to take your apron off now, please. I'd like to step back a little bit. Okay. If you take your outer gloves off now, please. Gel your hands. Okay, if you'd like to face me now, please. I'm going to take your suit off, so if you lift your head up. And if you turn around for me now, please. If you put your left hand on the bin, please. I'm going to hold your right boot if you step with your right foot over the red line. And the same with your left foot, please. Thank you. Okay. Okay, if you want to take your helmet off now, please. Okay. If you want to take your mask and your hat off. Okay. If you want to take your inner gloves off now, please. Okay, that's great, thank you. If you want to go and wash your hands now.
Before starting to take off their PPE, the SUA should clean the upturned bin and the alcohol gel bottle. After washing her hands, the clinical worker returns and applies alcohol gel to the SUA's gloves. Remove your gown, carefully folding and placing it in the bin. Clean your gloves with alcohol gel. Step out of your clogs into the amber zone. Holding your face shield at the sides, remove and place in the bin. Clean your gloves with alcohol gel. Remove your inner gloves and wash your hands using soap and water. Then put on a clean pair of gloves and place the lid on the bin. Make a visual check of the red zone to make sure all the equipment such as bins, wipes and gels and gloves are available. Discard your gloves in the bin by the sink and wash your hands. You can now exit the amber zone.
It's absolutely essential that the procedures for removal and for discard of PPE and the procedures for decontamination of the area in which it's been taken off, it's essential that all of those procedures are absolutely meticulous.